All right, we're ready to rock and roll. Thank you so much for joining us today and for your patience with those technical issues. We are going to take a look at the evolving role of infection prevention, the drivers behind the changes, and how we can embrace and advance both ourselves professionally and infection prevention as a profession. We are looking at the objectives here, and by the end of today's presentation, you'll be able to list external factors which have contributed to the expanding infection prevention role, describe how CBIC has contributed to defining the expanding role, list the 6 practice domains of the new 2019 APIC competency model and their relationship to advancing your skills as an infection preventionist, and plan next steps that you or a fellow infection preventionist, which you may be mentoring, can take to advance professionally. Lastly, you'll be able to identify ways to innovate and boost your infection prevention resources. So let's move on. We are going to begin by looking at the emergence of infection prevention and how that role has evolved. Evolving means to develop gradually from simple to more complex form. As we look at how infection prevention has changed over the years, it's clear that the role of the infection preventionist has become more multifaceted and involved. Let's rewind and look at the early years of infection prevention as it began to emerge. Next slide. In the 1950s and 60s, hospitals began developing infection surveillance programs. The infection control movement emerged in the 1970s as CDC introduced infection control staffing recommendations, which were 1 ICP to 250 beds at that time. The Joint Commission added the presence of infection control and surveillance programs to accreditation standards, and CDC created the NNIS HAI reporting platform, which we all know today as NHSN. In 1972, APIC was established by a group of innovative nurses which were joining forces to organize an approach to prevent hospital-acquired infections. Originally named as Association for Practitioners in Infection Control, as we know today, the name later changed to Association for Professionals in Infection Control and Epidemiology, and is now a multidisciplinary group of professionals. Next slide. In 1974, the SENIC project, a study initiated by CDC, established a link between the reduction of HAIs and infection surveillance and control programs in acute care hospitals. Specifically, a 32% reduction was found for effective programs. The study established that in the 1970s, very few hospitals had infection control professionals. However, the study identified later that by mid-1970s, thousands of hospitals had infection surveillance and control programs. And by 1977, 80% of hospitals had an infection control professional. At that time, 94% of which were nurses. Next slide. This next slide highlights some key developments that contributed to the evolving role of infection prevention. In 1999, the Institute of Medicine published the landmark report, To Err is Human, which emphasized infection surveillance as a model for voluntary patient safety. 2 years later, the IOM published Crossing the Quality Chasm. This report brought attention to the quality of health delivery and evidence-based practice. In 2004, the IHI, Institute for Healthcare Improvement, 1,000 Lives campaign engaged hospitals and healthcare providers to reduce patient harm, including prevention of CLABSI, SSI, and ventilator-associated pneumonia. The following year, 5 states, the first 5 states were introduced mandating HAI reporting: Pennsylvania, Missouri, Illinois, Virginia, and Florida. In 2008, APIC changed the name of the infection control professional to infection preventionist, highlighting a clear shift in the role of the profession to prevent infections. About the same time, the CUSP initiative, Comprehensive Unit-Based Safety Program, was implemented nationally. This HAI reduction methodology was developed by Dr. Peter Pavanoff at Johns Hopkins with funding from the AHRQ. In late 2008, Medicare no longer reimbursed hospitals for the cost of HAIs, preventable conditions, and mistakes. Next slide. In 2011, CMS introduced public reporting mandates for HAI reporting into NHSN. Pay for reporting was first introduced into acute care hospitals and later expanded to include other healthcare delivery systems such as LTACs and IRFs. That same year, CMS began posting HAI data on Hospital Compare to allow consumers the opportunity to compare infection rates between hospitals and make informed decisions on where they go for health care. In addition, this added motivation, of course, to hospitals to improve the quality and safety of patient care. In 2015, the CMS HAC reduction program began penalizing the worst performing quartile of hospitals. Those with a total HAC score greater than the 75th percentile are subject to a 1% payment reduction. Next slide. Over the past 2 decades, infection prevention has experienced major shifts in practice. Once a siloed expert working within their own black box, now infection preventionists are key stakeholders in collaborating and facilitating performance improvement throughout the healthcare organization. Formerly a profession known for expertise to control infections, now infection preventionists are subject matter experts and educators working on the front lines to prevent infections where patient care takes place. HAI surveillance, which began as voluntary and targeted based on infection risk, now also includes required public reporting based on CMS IQR participation rules and state public reporting laws. Next slide. There are many drivers that influence the evolution of infection prevention. As we saw in the timeline, public reporting mandates and HAI prevention collaboratives, such as the IHI 1000 Lives and CUSP, broadened the infection prevention role, emphasizing performance improvement, leadership, and paving the foundation for implementation science. In addition, emerging pathogens such as multi-drug-resistant organisms, MRSA, CRE, and more recently, CRS, have heightened the importance of infection preventionists in both inpatient and outpatient care areas to ensure safe practices are in place to identify, prevent transmission, and control these types of infections. Patients as consumers have become more knowledgeable about the risk of acquiring a hospital-acquired infection, especially with the media type on superbugs and Ebola. Patients as consumers are tuned into the risk that healthcare infection exists and are asking questions and are looking at Hospital Compare infection data when deciding where they'll go for health care. We are at the next slide. Okay, we'd like to pause a moment now and introduce you to Joan Kelly and have her share her personal experience as how she became an infection preventionist and some of the changes she has seen take place over the past 2 decades. So Joan, if you could tell us a little bit about your experience and, throughout the years, the changes you've seen as an infection preventionist over these past couple of decades.
Sure. I graduated from nursing school in the late 1980s. One of my senior rotations involved spending time with the infection control wound care nurse in an acute care hospital. During this period, HIV was evolving along with drug-resistant organisms like MRSA and VRE. It is at this time I gained a strong interest in infectious diseases. Throughout my career, I have seen many changes in the approaches to infection prevention. In the 1980s, clinicians were adapting to mandates on universal precautions. In the 1990s, needle safety devices were introduced as a method to prevent bloodborne pathogen transmission. In addition, many facilities volunteered to report infection control data to the CDC in a system called NNIS or NIST. This system today is the foundation for mandated NHSN reporting. Through this evolution, we have moved back and forth between whole house surveillance and targeted surveillance. The field today touches all areas of healthcare and has become a focal concern for our community. The reemergence of measles is a prime example of a public health issue practitioners face today.
Joan, thank you for sharing your experience. Let's go to the next slide. As infection prevention has evolved and continues to evolve, defining the expanding role of an infection preventionist is an important aspect of this journey. Let's go to the next slide. The word expanding means to open up, to increase the extent, volume, or scope of. As we go through the next group of slides, we'll take a closer look at how the volume of infection prevention tasks has expanded, as well as the scope of responsibilities. Next slide. CBIC, or the Certification Board of Infection Control and Epidemiology, began performing practice analysis for infection prevention in 1976, and they continue to analyze the practice every 5 years to capture the current IP practice. It's interesting to note that between 1982 and 2001, CBIC analysis found that infection prevention work tasks had increased by 145%. So from 60 work tasks to 147. CBIC updates the CIC certification test every 5 years to ensure that infection prevention competency assessment is based on the most current practice analysis. If you were able to go to the APIC conference or maybe already learn about it, APIC announced this year at the conference that, and CBIC announced, at the conference that beginning in 2020, those candidates who are eligible for CIC recertification can recertify now with CEUs as an alternative to recertifying by exam. In 2020, CBIC is also introducing an Associate Infection Prevention and Control entry-level pathway for the novice IP and those pursuing a career in infection prevention. Next slide. CBIC has defined the following core competency for infection prevention practice: identification of infectious disease process, surveillance and epidemiologic investigation, prevention and controlling of the transmission of infectious agents, employee and occupational health, management and communication, education and research. These core competencies are foundational to the profession and are also embedded in the APIC competency model. Next slide. APIC announced an updated competency model at the conference this year, and you are seeing that on this particular slide. The APIC competency model was first published in 2012 and introduced a future-oriented conceptual model which was applicable to all practice settings. The 2019 model further captures the dynamic, specialized nature of infection prevention and control. This model is intended to guide infection preventionists through the career stages and to further grow the profession. We've provided links to the updated 2019 APIC model on this slide. Next slide. The center of the APIC competency model continues to be patient safety, the main goal which infection prevention aspires to. New to the model is a focus on patient safety throughout the continuum of care. There are now 4 career stages: novice, becoming proficient, proficient, and expert, and 6 future-oriented domains which contain subdomains serving as a guide for career progression as well as professional development. The model conceptualizes skill progression at different rates within each domain, transcending the career stages. Next slide. New to the career stages is becoming proficient. a stage which is between novice and proficient. The novice infection preventionist tends to rely on infection prevention and control rules and concepts to guide their practice. As the novice becomes more experienced, they move into becoming proficient and building on novice competencies. Novice and becoming proficient infection preventionists can use the APIC self-assessment activity tool as a roadmap for professional development, and we've provided a link to that on this slide as well. The proficient infection preventionist demonstrates core competency, and CIC certification provides that formal recognition of that competency. The advanced infection preventionist has mastered infection prevention and control domains. Next slide. We have listed here the 6 future-oriented domains contained in the 2019 APIC competency model. They are unique aspects for development to advance competency. The slide provides the subdomains within each domain. An infection preventionist does not have to achieve a level in each one of these competencies at the same time. So they may be more advanced in one domain than another. So progression within each domain is not expected to be synchronous. Next slide. APIC provides a roadmap to guide new infection preventionists as they journey on the road to develop professionally and achieve CIC certification. APIC has defined stages of development. Stage 1 focuses on infection prevention basics and surveillance. Stage 2 is a time to build and expand the knowledge base. Stage 3, the infection preventionist begins to serve as a subject matter expert and develop soft skills such as communication, leadership, and teamwork. APIC recommends a number of ways for infection preventionists to grow professionally. Networking with facility stakeholders, developing soft skills such as leadership, joining local and national APIC, finding a mentor, and attending infection prevention training. The APIC roadmap is available online to APIC members. Next slide. APIC and CHICA, the Community and Hospital Infection Control Association of Canada, authored Infection Prevention Professional Standards in 2008. The standards were later updated to keep in pace with the evolving role of infection prevention as well as the APIC competency model. These standards are a foundation for the infection prevention profession and outline the role and scope of practice. The APIC professional practice standards reside on the outmost circle of the APIC competency model along with CBIC core competencies and serve as a foundation to guide infection prevention development and professional growth. Next slide. At this point, we're going to have Joan share how she uses the APIC competency model to evaluate and develop infection preventionists working under her leadership. Joan?
The APIC competency is a resource I use to help coach and expand the knowledge of the infection preventionists who work in my department. This model is used to train novice practitioners and prepare them for the CBIC exam. I also use this tool annually as part of a self-evaluation for my staff. This allows me to further assess their growing needs and seek opportunities for them to excel as a practitioner. I meet weekly with my IPs to discuss topics we have identified as opportunities for growth through the self-assessment process. We also conduct case reviews to ensure patients with an identified infection meet NHSN criteria. This competency model helps outline a professional development plan for my practitioners.
Thank you, Joan. I do want to just notate that the APIC roadmap for novices, that APIC is actively updating that, so look for some updates for that roadmap as well in 2020. It's an exciting time to be an infection preventionist. The expansion of this role has afforded many infection preventionists the opportunity to partner directly with stakeholders throughout their healthcare organization and forge a culture of safety. As we embrace this expanding role, we can equip ourselves for success. Next slide. So who are infection preventionists? Infection preventionists come from various professional backgrounds. Based on the 2005 APIC mega survey, nursing continues to dominate the field. However, other professionals such as medical technologists and epidemiologic graduates are increasing and bring a complementary dimension to the field. 44% of infection preventionists are master's prepared or higher, and 47% are board certified. Infection prevention years of experience is fairly evenly spread based on the survey categories. The stats suggest that a minimum of 20% are novice infection preventionists. Infection prevention job titles are an interesting aspect. 60% of infection prevention coordinators or practitioners, which are at the level of a staff nurse or non-management, infection preventionists in these positions are often collaborating with upper management and in a position where they must lead without authority. This is a valuable skill even for those infection preventionists who have achieved an upper management title. Next slide. Infection prevention practice has expanded beyond the acute care setting. 1/3 of infection preventionists are now working outside of the acute care setting, for example, in LTACs and ambulatory care. And this is part of the reason that the APIC competency model, the patient safety, now highlights a focus on the continuum of care. Next slide. No matter how many years that you have been in infection prevention, there's always more to learn and always more ways to grow professionally. The infection preventionist role will continue to evolve, and so must we to maintain our competency, meet new challenges that may come our way, and to grow the infection prevention profession. First and foremost, professional development is an ongoing process. Don't be a loner. Get connected by joining your local APIC chapter and building your infection prevention network. Join APIC National. APIC provides many resources, learning opportunities to members on the APIC website. Demonstrate your competency. Obtain and maintain your CIC certification. If you are advanced, work toward becoming a fellow of APIC. Consider other certification opportunities as well, such as CPHQ certification for quality, and also consider advancing your education. Next slide. The 6 domains of the APIC competency model contain both hard and soft skill sets. Hard skill sets are those specific abilities and knowledge that you learn and acquire as you advance your competency. Soft skills are personal attributes that allow you to be a successful leader and a change agent. Soft skills are harder to develop, but are essential to fully develop competency in each of the 6 domains. Next slide. Both APIC and, next slide, please. Oh, I'm sorry, you're there. It was delayed. Both APIC and NHSN provide a wealth of infection prevention resources, so we've provided some links for you on this slide. Next slide. There are many ways to become an infection preventionist. Most infection preventionists started out in another healthcare position, such as nursing or medical technology, and later moved into infection prevention. For me, I was working as an oncology nurse when I was recruited by our facility infection preventionist after asking her too many questions about Acinetobacter. Joan, at what point did you become an infection preventionist?
Later in my career, I became the infection control employee health nurse in a long-term acute care setting. After a few years, I chose to return to the acute care setting and continued to work in infection prevention and employee health. At my current hospital, I have grown professionally and will be celebrating my 20th anniversary in December. Through this employer, I advanced to a manager position, and today I'm the Vice President of Quality Improvement and Patient Safety. As Vice President, I have responsibilities over quality, risk, patient safety, infection prevention, employee health, and the inpatient wound care, as well as medical staff office. I strongly feel my experience as an infection preventionist has provided me a solid foundation for the job I do today. I am certified in infection control, rehabilitation nursing, and quality health care. I'm currently working on my master's degree in organizational leadership and project management. As a practitioner in today's healthcare environment, I feel professional growth is essential in ensuring patients receive the best care possible.
Thank you for sharing, Joan. Your career advancement from infection prevention coordinator to infection prevention manager and now VP of quality is a testament to the benefits of equipping yourself professionally and to the great work that infection preventionists do to keep patients safe. Next slide. In this next section, we'll look at ways that the evolving role of infection prevention has impacted infection prevention resources and some innovative responses to meet the increasing demands and responsibilities. Next slide. Infection prevention interfaces with stakeholders across the healthcare organization, working together to prevent infections. This shared accountability has blurred boundaries and can be challenging to navigate. Infection preventionists are faced daily with competing priorities. Sometimes there's just more work than can be completed within a workday, or a week, or even a month. Surveillance and public reporting demands have heightened the pressure to report timely and accurately. Unexpected priorities such as outbreaks or a surprise state inspection demand immediate attention, often postponing attention needed on other priorities such as surveillance. Work on the front lines to prevent infections and to remain survey ready is ongoing and essential. Staffing resources for infection prevention varies from one healthcare organization to the next. There are multiple variables which may impact infection prevention resources, such as a complex patient population, the experience level of the infection preventionist, and the environmental aspects which may bring additional challenges, such as on-site construction. Strained infection prevention resources are often acknowledged but frequently continue due to budgetary limitations. Ongoing demand for data by stakeholders can be another pressure point for infection preventionists. Many infection preventionists are crunching the numbers themselves, analyzing the data, and producing the reports for stakeholders. When surveillance is delayed due to other competing priorities, then the infection data for shared reports and public reporting mandates is at risk for delays as well. Next slide. There are multiple approaches to optimizing infection prevention resources. First, assessing the needs. Assessment of infection prevention resources and the effectiveness of the program will provide insight and best ways to approach optimization. Upticks in infection, poor performance indicators, missed public reporting deadlines, backlog of surveillance data, or failed CMS or state HAI validation audits are clear indicators that there are opportunities to improve and optimize. While adding infection prevention staff to your program is certainly one way to boost infection prevention resources, consideration of other approaches may provide viable options to enhance infection prevention resources. Partnering with stakeholders can both optimize infection prevention resources and engage departments in infection prevention initiatives and awareness. For example, some programs have successfully partnered with respiratory to help with VAE surveillance. Many facilities partner with nursing to obtain daily device counts increasing awareness of device utilization and device medical necessity. Technology such as infection prevention software can enhance infection prevention resources by helping to mine and organize data for surveillance and reporting. Some programs have partnered with an outside vendor such as Q-Centrix to perform their HAI surveillance and even NHSN reporting on their behalf. This strategy frees up the local facility infection preventionist without having to add additional infection prevention staff. Next slide. Joan comes from a facility which has partnered with Q-Centrix for infection prevention surveillance for many years. Our team is an extension of her team and enhances their infection prevention program. Joan, can you share with us some of your thoughts on ways to be smart with your infection prevention resources?
In my infection prevention program today, I encourage my practitioners to know their resources. The plant management, pharmacy, and microbiology departments are definite areas an infection preventionist should tap into. In addition, a practitioner should be familiar with electronic resources through the CDC, APIC, and regulatory agencies such as the Joint Commission. The local health department is another great resource. In our community, we meet face-to-face with community health leaders to discuss community health risks such as measles or influenza. A strong preventionist needs to develop leadership skills to gain commitment at all levels of the organization. Organizational commitment on the importance of infection prevention principles is essential for a program to be successful. Through informal leadership, the preventionist bridges communication throughout the organization, inspires others to adhere to best practices, and works to gain professional buy-in from everyone in preventing disease transmission.
Thank you, Joan. Next slide. In summary, the infection prevention role has rapidly expanded and continues to evolve today. Infection prevention is recognized as an important component in delivery of safe patient care and has achieved recognition as a profession. Take action. Equip yourself professionally so that you can meet the expanding responsibilities and challenges that are part of this evolving role. Explore ways that you can be smart about your infection prevention resources so that you can fully utilize the infection prevention resources available to you today and potentially enhance those resources to strengthen your program and reduce or ultimately eliminate infections. Grow the profession. Obtain and maintain CIC certification. Join and participate in your local APIC chapters and APIC National. And as you become proficient, be a mentor to other other infection preventionists. Consider advancing your education as well. Next slide. So we'll
thank you.
turn this over to Michelle.
Yes, thank you, Sarah, and thank you, Joan, so much for sharing your story. So we do just have a few questions for you guys today that came in through the chat box. To start, we have someone saying that they're newer to infection prevention or they're starting to look into this area. And like you, it wasn't the area that you initially had started in. What is the first thing that you would recommend to getting up to speed and building new skills?
So this is Sarah. Joan, did you want to take that?
Sure. I think for me, oftentimes there have been times where I have hired an individual with more of an entry level who's never been in that role. But I think, especially if you're a clinician, it's helpful for you to think back. Typically, people have a lot of knowledge when it comes to infection prevention. They just don't necessarily tap into it that way. They know how to prevent transmission of organisms when caring for a patient, and many of the concepts that they do in that care are just establish that foundation for being a practitioner.
And then to add to that, there's many resources. I would recommend joining APIC as a member. there are many, many educational modules on there that come with that membership that are no additional charge. If your leadership is willing to sponsor you to go to the EPI 101 and 102 training, that's another great way to get a boost and speed forward quickly. And then for public reporting, NHSN, and we gave you a lot of those links, but NHSN has learning modules for from learning how to apply the definitions when you're doing surveillance, and then they also have modules for how to actually go in and do the public reporting piece. Michelle,
Awesome.
we have another question?
Yes, I think this will be our last one. I think this probably questions for Joan. How would you recommend someone approach adding additional resources or getting additional resources to support the team? How would you kind of make that business case to the department?
I think for me, and this is coming from experience, when NHSN just really opened up all the mandates on public reporting, and then I'm also reside in the state of Texas, which also has public reporting within that state. As the manager of that department at the time, I averaged probably at least 75% of my work week sitting and reviewing cases online, which meant at the time in my facility, we only have 2 practitioners in that office. So that allowed one person to make rounds throughout the hospital while the other person spent many hours at the computer. I was able to kind of take that and adjust, you know, if I pulled away and could get Q-Centrix involved to kind of help manage the computer time and the day-to-day surveillance piece of it, then that would free up both the practitioners for that to involve for more roundings and show an impact on reducing our infection rates. So, you know, it's kind of, that was one area I used to project with, is with non-reimbursement and all these public measures, you know, how we could have a greater impact if I had 2 practitioners that then could focus specifically in particular departments. I think that's probably been my biggest sell. I think, again, having the numbers of reduced infections in our hospital has also had a great sell, because that helps them see, you know, the more time those practitioners are not behind a computer screen and they're out on the floor engaging with the clinicians and frontline staff on preventing infection, that we end up with greater reduction in infection rates.
That's great, and I think that's a really great point, especially when you have the numbers to back up, you know, that you were able to effectively reduce infections and improve patient safety. I think that'll definitely help make the business case for someone who's looking to add additional resources. So thank you for sharing that. So I think because we did run a little long, that is all the time that we have for today. I just want to thank you all again for joining, and special thanks to Sarah and Joan for sharing their insights and their stories with us. I just wanted to share that we will have some upcoming future topics for webinars around both IP staffing and resources, building the business case to get more resources added to your team, and then also hospital-acquired data accuracy and validation. And then lastly, I did want to say that this recording and slides will be made available to everybody probably early next week. And then if you would like to learn more about Q-Centrix and how our CIC certified infection preventionists can act as an extension of your team, please feel free to contact us at qcentrix.com. And once again, thank you everybody, and have a great weekend. Bye-bye now.